Thank you, Niels. This session is purportedly on growth hormone, and the next two folks who are going to speak are going to talk a little bit more about some of the growth hormone bits. But remember that growth hormone deficiency is really a pretty uncommon disease. We're talking about 1 in 3,000 or 1 in 10,000. And so I'm going to actually back up a little and speak more about growth and the evaluation of growth. And that way we can see where growth hormone deficiency may fit in. So let's see if we can, yes, we can. I come from the University of Virginia. This is the rotunda. Mr. Jefferson, our third president, was sitting up at his home in Monticello, which is about 5 kilometers from here and from the rotunda, and he designed it. So this is everything about the university is Mr. Jefferson. I love art about children, and there is a book from the turn of the 18th to the 19th to the 20th century from Poland, which has about 75 pictures of kids. I chose this one because she's asking the question, what are we going to talk about today? Well, that's what we're going to talk about today. So I'm going to talk about growth, normal and abnormal. Yes, there are statistical definitions. Measurement, I'll spend a little bit more time on than you probably care to. But if you remember how blood pressure and growth are measured, you can measure them one day. If you make a mistake, you can go back 5 minutes later and measure them again. But if you made a mistake 3 months ago, you cannot go back. And so that's why so many of our growth curves look like picket fences rather than looking like a nice smooth curve. And then we'll talk much more importantly about the evaluation of children, and that's where the issues of the growth hormone axis that you'll hear a lot more about from Peter Bang, who's going to talk after me. I'll give one very simple example of a child, and that will just give us an idea of how one might go about doing that. Okay. So definitions, short stature, very simply, -2 SD and a bit and below. Growth failure, I don't like that word because failure means failure. Most of the time kids aren't failing to grow at all, but they are faltering in their growth. And so I prefer the word faltering. And we quantify that by crossing the major percentile lines on the charts. We'll go over those, but please remember there are 2 times in life when you are permitted to do that. Once is when you are in the first couple of years of life, and the other is when you're an adolescent, depending upon whether you're early through puberty or late through puberty, and you'll see why as I go through some of these materials. And just as a spoiler about the end, the least common cause of poor growth is endocrine. So normal growth, it follows the patterns, we will see them, and just because you are outside of the limits at the tall side or the short side doesn't mean you are abnormal. Somebody has to be below there. But in fairness, the closer you are to the bottom percentile or the top percentile, but being outside, the less likely you are to have pathology. And I think the numbers are something like 50% will have pathology at -3.5 SDs. 3.5, that's not -2.1 or 2.01. These are the statistical curves that you've seen. The middle 68% is within 1 SD. Within 2 SDs is 95%. That's what we usually operate in. Now get your eyes down into the left and you will see some crazy numbers. And what you'll see here is, if I do it right, you will see -2 SD. And then you'll see third percentile. Third percentile is -1.88 SD, -2 SD is 2.3%. For all intents and purposes, those are the same number. Let's not argue that point at all. Some curves will have the third percentile on it, so let's leave that be. Then you see -2 SDs, -2.5, and this number in between, the -1.2 percentile, or 2.25 SDs minus. Does anybody know where that number came from? Hard science? Absolutely not. US FDA. They were arguing about this dreaded disease called idiopathic short stature. I do not know what it is. I got it, but I don't know what it is. And there was one camp that was mostly the scientists, doctors that said, oh, it's got to be minus 2.5. And then there was the other camp, mainly the drug companies. Oh, no, it's got to be minus 2. And so for those of you who are mathematically challenged, the average of minus 2.5 and minus 2 is minus 2.25, and literally that is how that number popped up. Those of you who are privileged to see the Lilly growth charts, there's this big fat red line at minus 2.25 SD because exactly this. So when you talk about short stature, you're talking about 2.5% of the population. When you're talking about growth hormone deficiency, you're talking about a fraction of a percent. So from the commercial point of view, it's clearly more important of the 2.25. That is a true story. I did not make that up. So physiology of normal growth, we're not going to go into it. They're genetic, nutritional, hormonal factors, and as we learn more and more, a whole bunch of psychological factors. Yes, you've all heard of psychosocial dwarfism or Widdowson's paper after World War II. My mentor and boss, Bob Blizzard's paper about psychosocial dwarfism and reversible hypopituitarism. But in fact, there are a lot of things other than objective hormones that lead to growth. And then growth hormone, thyroid hormone, and sex hormones are important. Now, the phases of growth, I will go over. There are 2 slides with words on them. This is Johann Karlberg's construct, and the 3rd slide that I will show you is going to have a picture to make it much easier. So intrauterine growth, growth strongly influenced by the environment. You knew that. Is the placenta hooked up right? Is mom malnourished? Is mom sick? Is the kid got a genetic condition? Insulin and IGFs and their binding proteins play an important role. You, of course, knew that. Why is an infant of a diabetic mother big and fat? Because of insulin. And GH, thyroid hormone, aren't very important. You already knew that too. Why do we screen for congenital hypothyroidism? The most common presentation of a hypothyroid baby is normal baby. And that's why you got to screen. They are of normal size intrauterine, except for iodine deficiency. And then for a growth hormone deficient kid, if you look very carefully, they may be 1/4 or 1/2 an SD small at birth. Certainly over the first 6 months, they don't grow so well. But that's why you knew all of that stuff before. You might not have just remembered that. In the infantile portion, it's all downhill, and I'll show you pictures of that. And then infants can cross percentiles. If mom is little, she ate a lot or she had diabetes and had a big baby, the baby has to catch down as opposed to the SGA babies that have to catch up. Childhood is boring. It's usually relatively constant growth. You can see in centimeters and in inches what the boundaries are. And there may be a slight slowing just prior to adolescence, and there may be a slight bump in the middle of childhood that Jim Tanner thought was due to adrenarche. I'll show you pictures of that. Pubertal, everybody grows the same at puberty. It's the timing and the tempo that counts, and that's where we have so many difficulties, and that's why you're permitted to cross percentiles then, because the growth spurt is built into the girls' chart at exactly the time that the average girl goes through puberty, and the same thing for the boys. Now, this is the slide that shows these things together. So this is a length chart. And so they're still making progress all the way up in infancy. That's the first part. You'll see the constant growth of childhood. You add that, that gets you 1 and 2. Everybody grows the same at puberty. As I said, the timing and tempo are what's different. Probably easier to see are these data, and you'll see why the vertical axis is now rate, height, velocity, growth, and the age is on the horizontal axis, and you can see the mid-childhood little bump, and you can see the growth spurt. This is the modern way of looking at things. Anybody know where these data came from? This is the late 18th century, Count de Montbéliard measuring his own son. So these data have been around for a long time, and they are so much easier, at least from my point of view, they are so much easier to digest than are the regular or usual growth charts. There are now actual data that show these in groups of kids, and one study, there are so many studies, very few of which are longitudinal. The next two slides come from the Barcelona longitudinal growth study, first in girls, then in boys. On your left is the usual growth curve, and on your right is the height velocity. I like that one the best, and I will show you in two slides how all these things line up. What you see is those who grow, go through their pubertal growth spurt early, have a peak growth, in this case, let's see, a little bit over 8 centimeters, and then she would stop growing a lot earlier, and the other girls would have a little bit more prepubertal growth, but would not have quite so high a peak. The boys are no different, except for the numbers. The peak height velocity is higher than in the girls, and this is the way the curves look. Now, there are very few of my slides that you must remember. The next one is one of them. So, yeah, you got to remember that. This is what the growth curves look like. Does anybody know what that broken line is? That broken line is the average growth. Nobody grows average. That's why you need longitudinal charts. And so what we have here is those who go through puberty the earliest grow, have a peak height velocity of the greatest, and those who wait to have their growth spurt don't have a growth spurt quite so much, but they grow pre-pubertally longer. I won't convince you, but the area under the curve, or the total amount of pubertal growth, is essentially the same in all of them. This is the key element here. So if you line up the data, not by calendar age, but by biological age, when they had their peak height velocity, which is an extraordinarily good biological anchor, that they all grow the same. Now, does that help us as clinicians? Hell no. Because we see the kids on the way up or not making it on the way up. If you knew the data already going down on the right-hand side of the curve, then you wouldn't have any trouble, but that's not when the kids come see us. The kids come see us at 12, 13, and 14 when they're not making progress over here, and you can't picture the rest of this. But in retrospect, in longitudinal studies, this in fact is the way kids grow. All right, well, if you want to make a growth chart, you got to have raw data. And the only way to get raw data is to measure kids. And my point that I'm going to make over the next 4 or 5 slides, it isn't that much harder to measure kids correctly than to measure them, because you can't go back and measure them from a month ago or 3 months ago in case you made a mistake. That's one of the few places that I like electronic medical records, because if you bring up the record and you see that the point doesn't fit with your other points, you can go back and measure the kid again. So Norman Rockwell is one of my favorite painters. This is one of his New York, I forgot which magazine. He used to do magazine covers. I think it was the Saturday Evening Post, I'm not sure, but I just love those pictures. So the infant stadiometer is actually usually on the tabletop of one of your pediatric examining tables, and it's actually a 2-person sport to measure a little kid, because the more vigorous a kid is, the shorter he is. Kids don't like to be stretched out, and so they bring up their knees and are shorter, and so you have over here, if we could see it, usually mom at the head makes sure that the head is against the other board, that is the non-movable board, and the attendant at the other end is pressing down on the knees and pushing the footboard up. I don't know if there are any of you that are old enough, as I am, that in the delivery room we used to measure kids by holding their feet with a tape and measuring this way, and again, the strongest kids were the shortest kids. Now, I know in the next 2 slides, none of you would do any of these things, but we have kids that are measured this way, and now, it was only 1 slide. And now we'll talk about the childhood stadiometer. That is the position, heels, rear end, shoulders against a board of a fancy apparatus. But for those of you who don't want to spend that much money, and it's really not necessary, in the growth clinics we have them, if you get a steel ruler put up against a vertical wall by a proper carpenter in the right orientation, and you take a very inexpensive right triangle, plastic right triangle, you can get almost as good data from that. We usually measure kids twice. If they agree within 4 millimeters, if they don't, we measure them a 3rd time. Our attendants do that. They practice, they know how to do it. Again, as I said, it's not that much of a bother to measure kids correctly than just to measure them haphazardly. Even at my institution, when I got there, we had 2 kinds of measurements. General clinical measurements and endocrine measurements. Remember, Bob Blizzard was there. And then for my friend in nephrology, we had regular blood pressures, and then we had nephrology blood pressures. You don't need to do that. Do it right the first time. And then none of you have seen these kinds of machines. My father, who was a general practitioner 70 years ago, had such an apparatus, and all my life growing, not much, but still growing, I was measured on one of those apparatuses. So I'm going to spend a little bit more time now on the WHO growth standards, and I'm going to make a very strong plea about standards versus references. Now, WHO data have been touted as being the best around the world, and everybody grows the same, with the exception, I think, of the Danes, who have enough data to show that the WHO probably isn't quite so good for the Danes. Maybe other groups as well, but we sort of use the WHO, and I'll go through how they came about versus the other. So thus, children who are starting out in life optimally, they're being fed well, they're being taken care of, grow the way the WHO shows, and I'll talk about differences between them, and it replaces the references that we've had before. In our country, we use CDC, Centers for Disease Control charts that were cross-sectional. So the growth standard came in multi-ethnic from Bangladesh to the US to, I think there was one place in Scandinavia, I can't remember whether it was in Sweden or Denmark, to a single international standard reflective of the global community, and they thought that all of this would be correct when their nutritional needs are met. Yes, there are data up to 5 years, but there are very few places that I am aware of that really religiously use the age 2 to 5 charts. A lot of people use the 0 to 2 charts, not so many use the 2 to 5 charts, and I don't know why. Their nutritional needs are met, again, with a little caveat of psychosocial aspect, but when these data were got, you'll see why that wasn't a question. So the differences between them, one is a growth reference, the data are older, the feeding was quite different, and there are some questions well over my head about how the statistics were done. There are arguments among the statisticians. I'm not sure what they have decided. So the WHO charts, WHO, birth to 2 years, 882 infants. First of all, that's a pretty good number of infants. The cohorts were multiple sites, but the key element here, in addition to the nutrition, is these were all high SES, socioeconomic status people. This is not a cross-section of the countries in which they were done. Infants were measured 21 times. Now, again, for those of you who are mathematically challenged, 882 times 21 is a bit over 17,000. So they had a whole lot of information. And so the standard essentially means this is how kids should grow. And the point was that despite the fact that Scandinavians and Japanese may be 20 centimeters different as adults, in the first 2 years of life, it was considered that they would be exactly the same. The exactly part is what is in question. Now, let's look at these two sets of charts. On the left is the length chart, and it almost doesn't matter whether you're looking at the red line or the sort of orange line. They're pretty much the same. But look on the right. The right is weight, and if you think the WHO is the correct one, which is what the argument is, that would simply mean that most kids around the world, based on the older charts, were overfed. That's essentially what that means. Now, are there implications for that for those of you who are pediatricians? Yes, and they're on this slide. So if you put your eyes to the left, you are now looking at the prevalence of low length for age. Just as you looked on the left on the previous slide, it doesn't matter whether you're yellow or whether you're orange. But put your eyes to the right, and you can see the difference, especially between the ages of 6 months and 24 months. This is that dreaded condition called failure to thrive. They are underweight for age, not underweight for length, but underweight for age. That's what moms and grandmas and doctors talk about. And think of, if you're going to refer to another doctor, whether it's an endocrinologist or a GI doc, for failure to thrive, think about the difference in number of referrals and amount of angst for the parents and the grandparents just by plotting the kids on an appropriate chart. This is a big deal. All right. So let's transition. Another factor in measurement. I'm always short at the end of the month. Well, I'm short at the beginning of the month too. So let's evaluate children and adolescents with short stature and what is its differential diagnosis. This is how I will start to get into the growth hormone business that will be picked up by the next speaker, and then a little bit more general about growth plate by the third speaker. So if you didn't think I'd start with a growth curve, you need remedial work. You gotta start with a growth curve, and I made the plea that you gotta have good data for that. Is the child short, yes or no? Doesn't mean the child's sick, but is the child short? Does the child have growth failure or faltering? Quite a different issue. And then personal, family, and social history. Now, I bet Ola is gonna get into this. We used to think that mid-parental height meant mid-parental height. You figured out that mommy and daddy, where they fit on the chart, and the kid was supposed to be in the middle. But when there's a big disparity between mommy and daddy, where mommy may be 148, 150 centimeters, and dad may be 185 centimeters, sometimes the calculation doesn't work, because now there are more and more autosomal dominant conditions in which mom and the kid may very well have the same condition. So we have to be careful about that, and I bet Ola is going to talk about some of that. Physical examination for us, remember, we're specialists, for us isn't so helpful because they've been seen all their lives by a pediatrician. So if something's really obvious, it's going to have been picked up. I'm talking about dwarf, some kind of chondrodystrophy or something on that order. Physical examination is just what I mentioned. Bone age, we'll come back to that, but a bone age film can be very helpful. For those of us in peds endo, we're pretty darn good at reading bone ages. What we miss, though, are the very mild skeletal dysplasias that might show up in the fourth metacarpal or something else, or at the wrist, an early Madelung deformity or something on that order. So the radiologists really do help us in that part of it. And then the laboratory evaluation, and I will throw out some controversial stuff about not doing very much, despite the fact that what we do as endocrinologists is tests. I mean, that's essentially all we do. Okay. So accurate height, I'm not going to go into that. Body proportions, yes, in endocrine, in genetics, we're very careful. We can do sitting height, or we can do span, etc. But usually from the general point of view, and even when the kids first see us, the eyeball test, what the kid looks like, is usually pretty helpful. Measuring upper-lower ratio with the same kind of tape that I mentioned how we measured kids before really isn't helpful, because remember, if you make a mistake in the numerator, it is compounded by a reciprocal mistake in the denominator. Dysmorphic features, obvious ones. If the kid has Turner syndrome, the young lady has Turner syndrome, and she read the textbook and knew what she should look like, it wouldn't be missed. It's those that are a bit more subtle. And remember, at least in Turner syndrome, approximately 50 and maybe a little bit more % are mosaics. And so that they have fewer and fewer of the dysmorphic features that you might expect from a girl with Turner syndrome. The neck, both from the dysmorphic point of view, of course, that's where the thyroid sits. Skin is the biggest organ around, so looking for lentigines, looking for other spots, and pubertal staging. So this is what I'm going to throw out. There are data. I'll show you at the end where you can find the data. Patient with short stature, normal height velocity or normal growth, and no signs or symptoms on history or physical exam. Consider following the patient without laboratory studies, or not perhaps, I would recommend doing a bone age at least. And so these are the kids that every one of us has seen, certainly as a general pediatrician, and those that kids are angry enough, the parents are worried enough, the pediatrician's worried enough, we get to see. And most of them are short kids of short parents, so we call them Scotty dogs, because Scotty dogs have Scotty dog puppies, and very appropriately in this country, Great Danes have Great Dane puppies. And so that's one of the things that we can work with. Now, these are the things that have been recommended for doing workup of short stature kids. Bone age we talked about, a blood count and sedimentation rate or C-reactive protein, something to do with inflammation, being concerned about bowel disease. Metabolic panel, that's what CMP is, your analysis. Karyotype, we used to mention to our pediatrician friends not to do them because they are of various quality. And in fairness, the usual one, at least in our country, that gets paid for is 2 cells, and that doesn't help you when you're trying to diagnose Turner syndrome, when many are mosaics. And the genetics folks say you probably should count at a minimum of 30. Some say 50 cells. It's a lot more expensive. Free T4 and TSH, because thyroid deficiency is so common? Absolutely not. It's that the tests are done well almost everywhere, and if you get an abnormality there, that's relatively easy to fix right away without going into a big workup. The condition of celiac disease is relatively common, about 0.5%, and then when you have girls with Turner syndrome, it's about 10-fold that, or about 5%. So there are some reasons for doing that. IGF-1, we used to ask the pediatricians not to measure that. Peter has so many stories about IGF-1 measurements, but in fact now the measurements are getting better, and as they're moving over actually to mass spec rather than the immunologic ones, which could differ by easily 100%. And so then, as I said, I'll come back to why you might not want to do any of those tests. And so every one of us has our favorite way of going about classifying kids with short stature, which means how do you move through an evaluation of them. This is one that works for me. So you start out with short stature. Is the kid short or not? And there's a caveat for that. Is the kid short for his parents or not? So if your parents are up in the Great Dane range and you're down in the Scotty dog range, but on the chart, you may very well have a condition. Every one of us has picked up some relatively short girl with Turner syndrome who made it to the bottom of the growth curve, but her parents actually told her to be very much taller than that. So then once the short stature is confirmed, is it pathologic or is it normal variant? Normal variants, these are probably pretty much in scale, are probably about 80%. So you've got short stature that's non-pathologic, that has mostly the familial short stature that I talked about and the constitutional delay that we will come back to. Are they proportionate or disproportionate? That's the skeletal dysplasia business. Prenatal are mostly from history, and then postnatal are the textbook of pediatrics that you all have now online rather than on your bookshelf. And so we need to remember that growth is what's natural for kids. The general health of a child or adolescent is good if she or he is growing normally. Almost anything, be it mild asthma, be it steroids for 6 weeks, can tip the balance. And then the genetic expectations that we talked about. And that's what you see here. I'm sorry about the English measurements. 5 inches is 13 centimeters. And the issue here is then one grows to one's parents' mid-parental SDS, not mid-parental height. And so you have to make a mom into a boy. For a boy, add 13 centimeters to hers. You need to make a dad into a girl if you're looking for the mid-parental height, target height, by subtracting 13 centimeters before you go ahead and take the average. Notice what's at the bottom. 2SD is 4 inches, 10 centimeters. So if you're in the middle, just picture this. If you're in the middle of the usual chart, it's the whole white area that's within the 95th percentile of mid-parental height. So yeah, you can calculate it. It's not that helpful for an individual child. The normal variance, we talked about the first 2. The third one was implicated a little bit today in the CAH talk, that you can go through early puberty, not precocious puberty, but early puberty. That is reasonably common in especially girls who were born SGA. They're relatively short. They start puberty on time, and then they just rocket their way through puberty and lose a fair amount of height. So early puberty in someone who was born SGA is an important condition to follow, and rapid puberty, that's what I'm talking about in the SGA kids. Now, it took a professor of biostatistics at Harvard to tell us as children get older, they get bigger. Okay, I believe that. So to summarize growth, there's an enormous amount of information on this individual slide. And what you see here is it's a boy. You see his height, you see his age. You go ahead and see where his mother and father were. Remember, this is their height centile and mother's height centile, so the average is taken up. The open circle is the boy the way he is now. Measure his bone age, which is an indication of his biological age, and that pushes him back to the 50th centile as if he were a 10-year-old, which his bone age is. And again, to make the math easy, daddy's at the 75th centile, mommy's at the 25th. The average of those is the 50th. That's where he is now and expected to go along that curve. Yes, he will fall off that by his calendar age, as he already has, because he hasn't gone through puberty. But all of that information is on this particular slide. And for extra credit for the exam at the end, can you tell me what the break in the curves are at age 2? That's when you stop measuring them lying down and start measuring them standing up. They're about 3/4 of an inch, maybe a centimeter and a half smaller standing up, because the discs between the vertebrae are kind of squishy when you're that young. So there are many factors that can affect growth. And if you start with SGA, IUGR, uterine growth retardation, undernutrition, GI disease, you can see how important nutrition is. Systemic disorders could be nutrition as well. I did mention, I won't go into it any further, psychosocial deprivation, not the kind that I mentioned Bob Blizzard wrote about, but well under the tip of the iceberg, a number of genetic disorders which might include undernutrition, and then the last are endocrine disorders, and we'll hear about growth hormone and we'll hear about thyroid this afternoon. Now we get back to the same thing. Consider, with the conditions in the first bullet, consider following the patient without laboratory studies or perhaps just a bone age film. The paper that this was written about from Cincinnati, there are a lot of difficulties with that because of the numbers of patients and what they did. And then the note on the bottom is the editorial that I wrote about it. Essentially what was said, if you follow the guidelines that our society, Pediatric Endocrinology Society, with the SBA and European Society and others, to get 3 diagnoses out of 258 kids out of 1,200, you would have spent about $108,000 per kid, per diagnosis. And so that's why the point is, folks, especially pediatricians who know these patients, following them is a lot better than sending them to see us once early on, should these things follow. So what about treatment? Well, treatment is diagnosis dependent, and you can see the kinds of things that one might use. And of course, I can't stop using endocrine stuff. We don't use it very often. We do, but general pediatricians don't use it very often. So those are the kinds of things. And I want to finish up with really what I think is a very, very important slide. And that's this one from out of Grimberg. The medical problem in yellow is easy. You don't need to be a doctor to do that. A technician can do that. The social problem, probably there are a lot more skilled people in psychology and social work than we are. The reason we're doctors, the reason we do the things that we do is the overlap in the middle. It's trying to integrate these things to see which things are more important, which things might be less important. So the place where you really need us as doctors is in the middle. So short stature is a common concern in pediatrics. Growth is an important indicator of health. Primary care must identify children with abnormal growth patterns. You know these kids and their families the best. Decide whether further investigation is needed and refer then to a specialist. Notice, I did not say refer to an endocrinologist. You may, but a GI doctor or a pulmonary doctor may be the appropriate doctor based on the history, based on the family history, etc. So, evaluation of a child with slow growth, a detailed history, clinical exam, growth curves, growth curves, growth curves, and additional confirmatory tests as necessary. So rather than doing the shotgun approach, we can tailor the evaluation to the patient and identify the normal variance. That'll turn out to be 80% or thereabouts. Attenuated growth is virtually always pathologic. Treat the underlying cause. And I will leave you with this. Is short stature a handicap? Some of us wouldn't think so. Thank you so much.